I'm Windsor Ting. I'm one of the vascular surgeons at Mount Sinai. Subject of my presentation today is venous wall stent. Venous wall stent is a little different in material from the other stents that's currently on the market. It's made of alloy, is rather than nitinol. It's a closed cell design and is self-expanding. It was just approved for venous indication in 2020. What's remarkable about the wall stent, it's been used for over 20 years. So it has tremendous breadth of clinical history and experience with this particular stent. Personally, I find it to be quite versatile, and it's flexible. And another feature of the wall stent, which I really like, is that you can resheath the stent. So as you're deploying the stent, you're not quite happy about the position and location of the stent, you can resheath it and reposition the stent. When we are talking about venous stenting, really what we're talking about is treating May-Thurner. That is by far the most common venous stenosis that we see. Here is an illustration of the venous anatomy, and on the right side you see a very typical CT scan showing May-Thurner. You see the left common iliac vein is being sandwiched and compressed between the right common iliac artery and the spine. And take note that this compression is bone and artery. This is a stenosis that is correctable with stenting. This is very different from another venous compression in thoracic outlet, where the compression is bone-bone, clavicle, first rib. Their venous stents, they don't do very well. So this is the pathology that we want to treat. Two very common venogram of someone with May-Thurner. Actually, it's two separate patients. And you see here, you can see the very proximal iliac vein is very dilated. But actually, it's not dilated. It's pancake against the spine. It's very hard to tell on the venogram exactly where the stenosis is. Here is another venogram, again showing May-Thurner. In fact, I think I just did this case this week. This patient has a very severe stenosis at the common iliac vein. And in both cases, it's very hard to see where the actual stenosis is located. And that's where IVUS becomes really important in these cases. It helps you localize where the stenosis is. In most May-Thurner, the stenosis is at or very close to the orifice of the common iliac vein. So to have a good outcome from venous stenting, you need to place the stent very precisely, and you need to know where the stenosis is. So when you put a stent, there are several different options. You can put unilateral stents, or you can put bilateral stents, kissing stents. Here I took this diagram because it really illustrates where you can put the stent. If you decide to put a unilateral stent, you can put it a little further in the vena cava. The problem there is that over time, it will impair flow from the contralateral iliac vein. Interestingly, it doesn't happen very quickly, but over time, you wait years, it will happen. And you put it halfway into the vena cava, even then, there will be some impairment of the contralateral iliac vein. And it's also really important to keep in mind that after you put a stent in these patients, the whole anatomy in the IVC confluence changes. And you don't know exactly what the final anatomy is going to be like in 3 months, 6 months, or further down the road. Or of course, you can put the stent very precisely at the common iliac vein. I can tell you it's not so easy. So these three separate patients showing some of the problems that we have encountered putting stents in a common iliac vein. Here, the stent looks pretty well placed, the left common iliac vein stent. But as this patient came back with recurrent symptom on the right side, and then if you can tell, even though the stent looks relatively well placed, there's actually stenosis. The stent is impairing flow from the right side. And then in this middle venous fluoroscopy, this stent is way in, too far in. It completely impair the flow from the right common iliac vein or the right iliac veins. What's very interesting is that the patient doesn't come back with symptoms early on, but as I mentioned earlier, they will return. It's just a matter of time. Here in this last venogram, these two stents were perfectly placed, so well placed that the actual lesion were missed. So this patient had stent placed on both sides for proximal common iliac vein stenosis. And if you look at the fluoroscopy, it looks really well placed, right at the right place, right at the common iliac vein on both sides, but it missed the lesion. So another way to treat May-Thurner is with kissing stents, and this illustrates one of these cases. Usually I access both common femoral vein. I like to use 16 or wall stents. So in the past I used 18 for male and 16 for female, but I find that 16 works well for both male and female. So I've used 16 in just about every patient. And the length of the stent, depending on what lesions, what other stenosis the patient may have. Here, I position, let's see, I can show you this. So I deploy both stents, but I didn't fully deploy the stent. So I position stent and extending for some distance into the vena cava. It's very important to make sure the stents are at exactly the same level. You don't want one stent to be slightly higher, because if you do that, the vena cava can tent over one of the stent and cause an outflow obstruction on the other side. So it's really important to place these stents at exactly the same level. So usually what I do, I deploy one side first. And here you can see I deploy the left stent first. And you can actually see the stenosis here. And then once I know how the stent is positioned, I then deploy the other stent. And here on the right side, you see the completion venogram and good flow, brisk flow through the stents. And the patient, actually I saw this patient after patient did well. Thank you.